Warm greetings to our esteemed Fogsi President, Dr. Sunita Tandulwadkar, and our distinguished guest, Dr. Devendra Khandai. Affectionately, we call him Deva. A very good evening to one and all. I extend a heartfelt welcome to the ever-growing audience of Gyan Pravah, the podcast series. We are thrilled to have participants joining us from across India and around the globe. Welcome to episode 217th, brought to you by the Clinical Research Committee of Fogsi under the dynamic and visionary leadership of Dr. Sunita Tandulwadkar, President of Fogsi 2025. ज्ञान प्रवाह हर घर फॉक्सी के साथ रोज नए रंग हर रात 8 बजे बाद. I am Professor Dr. Surekha Taide, Chairperson of the Clinical Research Committee of Fogsi and your host for the evening. It is my distinct pleasure to welcome our guest speaker, Dr. Devendra Khandai, Country Lead Health, State Health Systems, and Deputy Director at Gates Foundation, whose insights will enrich today's conversation. We are about to delve into a topic of tremendous relevance: scaling impact for women's health, transforming health systems in India's heartland. With great pleasure and honor, I take this opportunity to welcome and introduce our own Foxy President, Dr. Sunita Tandulwadkar, a visionary, a trailblazer, and a true architect of transformation in women's healthcare. Where vision meets action and leadership shapes the future, there shines a guiding force, Dr. Sunita Tandulwadkar, pioneering progress and empowering lives. From a visionary dreamer to a change maker in action, Dr. Sunita breathes life into ideas, turning them into institutions that stand as pillars of hope and progress. She nurtures potential, shapes leaders, and empowers countless individuals to rise with confidence and with customary leadership.
Surekha, I'm feeling very awkward in front of you all. I'm very small lady, and today's podcast is about Deva sir. So please, I'm so glad to hear such a kind word of appreciation from you. I don't know I deserve every word, but try to be as optimum and as idealistic as possible. But thank you so much, dear. I'm sorry to cut you, but it is too overwhelming to listen to all those beautiful words. Let me be grounded only.
Thank you, ma'am.
And I'm so thankful to you, Surekha, for having such a personality today for your podcast. Uh, as you say, we fondly call him as a deva. I just loved that word. And thank you so much for listening. Of course, I'll be listening to your complete CV, what she will be reading about. But whatever the 4 words she spoke about you, sir, I'm absolutely amazed. Thank you so much for coming on a Foxy platform. I join every night at 8 p.m. just to welcome the faculty. Frankly speaking, this all Gyan Pravah or podcast series was all program I curated for my chairpersons because they are the future leaders of a Foxy. It is like on a first ladder they become a chairperson and then they climb up and few of them reach to the top position. So I thought I give them a platform where they can have their dialogue, the confidence, the oratory skill, the vision, the passion, the creativity they can create in getting people. But believe me, sir, 217 faculty I made till now. And I don't know about my team, but I definitely evolved in my thinking, in my vision. There is so much more beyond the OBGYN. You realize the world is, and life is too short to do so many things in life. So thank you so much for coming and giving a different direction for this Pravaha. Surekha, she is my one of the most dependable, sincere, honest, intelligent chairperson I have. Anything I give her, she never have no word, including I say, Surekha, 2 days down the line, there is a very important, I think, which was that meeting? I don't remember, one international meeting. And probably I was coming from some other country. The flight may not land in time. Can I request you to go to Mumbai and attend that? She, with the blink of eyes, she said, yes, I'll go. You don't take so much stress, and she attended. That is dependability. That is a leadership quality. That is owning the responsibility of the chair. And Sureka, I will never forget that day and that conversation. And that is why I involve you more and more in my all projects. And you are not aware, I'm waiting for you to finish up the UNICEF project, which I gave you in your hand. And I'm taking you to another very big international project. But I thought, let 3 months go and finish up this project. And from January, I'm taking you in another project because I really need a people who work for the society, who work for the organization, who have a passion to perform. So thank you so much. Thank you
Thank
for
you, ma'am.
being a part of Foxy.
Thank you so much, ma'am. And I'm really proud to have you as mentor because you're one leader who will hold the hand of the juniors, or you may say the teammates, and make them rise. Thank you so very much for
So, Rekha,
being
it is
there
very
for us.
simple. One man cannot do anything and everything. So they need a dependable team members.
Thank you. Thank you so much. And now let me introduce none other than Dr. Devendra Khandai, a highly respected academic leader, educator, and public health expert. Dr. Devendra is country lead state health systems and deputy director at the Gates Foundation, where he leads work in Uttar Pradesh and Bihar, the foundation's priority states. A medical health professional with over 25 years of leadership experience, he has served as physician, researcher, teacher, strategist, and mentor to health professionals and NGOs across India and abroad. He has played a key role in polio eradication, immunization programs, new vaccine introductions, and efforts to eliminate TB, Kala Azar, and lymphatic filariasis. His current focus is on reducing maternal and newborn mortality by strengthening health systems, improving quality of care, developing innovative models for human resources, and nursing reforms, enhancing supply chains, and advancing women's empowerment through self help groups. Before joining the Gates Foundation, Dr. Khandai worked with WHO's National Polio Surveillance Project for 11 years, eventually becoming the national team leader. He has delivered lectures at leading institutions, including LBS, NAA, JHU, and CDC Atlanta. He has authored 50 plus research papers and received the honorary fellowship of the Indian Academy of Pediatrics for contributions to immunization and newborn health. I'm very, very proud of you, Dr. Devendra. He is my really very dear friend and my batchmate also. So I'm really proud of Deva here. Welcome, Deva.
Thank
Dr.
you.
Devendra, we have two projects, Sampurna and Do TK Jindagi Ke. Surekha will talk to you later, obviously. We will be more than happy to have your guidance, your help, your suggestions. And anyhow, if these programs run successfully, will make definitely a difference in maternal mortality as well as health of a woman, because we want to eradicate cervical cancer as well. So maybe sometimes we'll discuss. And our protocol is you both are in the picture and I listen to both of you from the viewers link. So have a great
Thank
time
you.
together.
Thank you
Thank you
so
very
much.
much, ma'am.
Thank you.
Thank you.
So, Deva, let's go ahead and have this great conversation. Deva, you have worked in diverse settings, from polio eradications to maternal and newborn health. Could you share what inspired your journey into large scale public health leadership?
So first things first, Surekha, thank you so much for inviting me on this podcast. It's absolutely honor and privilege to be here. Thank you for your extremely kind words. I think I think it was coming more from a lens of affection as a batchmate and rather than accomplishments, my accomplishments. So I just wanted to be very sure about it. Um, what inspired me, I'm still thinking about it. If I know the concrete answer is no. Um, but I think born in a very uh, hard to reach area of Maharashtra in a access compromise setting where challenges were there. Um, there is a particular age at adolescent when you think you okay, I want to become doctor, or those days doctors are engineers. But I think there is very strange idea was always at the back of the mind that oh, I want to do something different. What that something different? I don't know. I think, and I think in Vidarbha and specifically in Maharashtra and particularly in Vidarbha, there are enough champions and enough towering personalities who can inspire you to move towards public health, whether it is Baba Amte and the entire family, Dr. Bang, Ravi Kolle, and the whole setup is, and of course, this is the land of Gandhi and Vinoba Bhave. So this whole, in a way, there is a constellation of enabling environmental factors which gives you enough motivation to do something different. And that was, I think, when I look at why I may have joined public health, probably this where somewhere it will fit here. But more than why I joined, because it is that adolescent decision. I think more and more I work, there were two things which I thought like they are constant themes in my head. One is I am not very comfortable with impact at a small place or small geography. Now, and that's a block here. I am in slightest or not even remotely suggesting that's less important or something. That's extremely important. But somehow I am not very motivated to do impact at a very small job. That is one. Two is, I think, more and more I started moving around and working in and fall in love with my work in public health, in starting with polio eradication. I realized that if you want to make a change, uh, then it is the system that has to be, you have to work with several system levers. You cannot just work at one place and say, oh, everything will fall in place. It may take a long time. So that system lens was always there. And the lastly, even today, and matlab, I think thanks to the polio eradication, I had an opportunity to visit, I think, length and breadth of the country, opportunity to stay in 200 plus district, 220 actually, 220 districts in India. I think even today when I go and I very frequently go to the field, I think you you work with several stakeholders and you put that seed of a particular change, and when you go on the ground, you realize okay, that seed now it is converting into tree and blossoming into a bigger tree, and there is a lot of work which needs to be done. So my thirst for more change for the most marginalized is still continuing. It only, I think, going to the field is only telling me that okay, the path which I have chosen is a soul soothing path. I will say this journey is a soul soothing journey, and that's the way I will describe my journey.
It is so good to listen to you Devendra, and really, all of you are really proud of you. And rightly said, when I became a gynecologist, I thought I'm doing a great job when I'm, doing some big surgery or, having some successful outcome. But over the time, I also went into public health, into in the community.
Right.
And as you said, then we are not, satisfied with that small impact. We want large impacts and the ripple effects in the community. And that is what, then feeds more, thirst into us to do better, to do more, to do on a larger scale. And definitely public health is the field where we can have a greater impact, and specifically in those states, like I said, in your states have been Uttar Pradesh and Bihar. These are the focus of Gates Foundation as well. So in these states, when we do something and when we achieve, then I think that feeling of satisfaction of being a doctor, that comes to us. Rightly said, I think. And Deva, your these two states, why do you think that these states are so critical to India's health story? And what are the biggest challenges in strengthening health systems in these states, UP and Bihar?
So thank you, Surekha. I think before coming to the UP and Bihar, I think in polio eradication, I had an opportunity to work almost in all of North India, plus Maharashtra and Gujarat and many other states. I think the northern Indian states, and it's not the question of UP and Bihar, the overall northern Indian states, as far as maturity of the health systems are concerned, they are at a different level than the southern India states. Right? That is one. Second is, even in the polio eradication, and not only in this MNCH or SDG related goals, these northern Indian states were the states with the, specifically UP, Bihar, high population density, infrastructure, and the overall constellation of several factors which will continue or which will allow the intensification of disease transmission or any other one. So that's the story across. UP and Bihar, I think when Gates Foundation started working beyond HIV, and in HIV, so general Gates Foundation approach was, we will work in the most priority geographies where the possibility of impact is higher. And that's why in HIV, it was the southern Indian states where the burden was higher. Whereas when it comes to the overall family health goals like maternal mortality, neonatal mortality, undernutrition, family planning, immunization, infectious disease, etc., etc. So this group of things, I think in UP, Bihar, just a size. Just by the population, simple calculation, every fourth Indian is either from UP or Bihar. Right? So that means if you are working in UP and Bihar, that means you are working in 1/4 of India. It's not two states. It is 1/4 of India. If by just hypothetical imagination, if it would have been a separate country, it would have been the 5th largest or 4th largest country. So imagine the size, and that's why whatever health needle that is moving in these states, it will have bearing not only on the India indicators, but the global indicators also. That is one part. Of course, if you are in public, so you are a gynecologist, the thing which you enjoy is most is when you get an opportunity to handle the most complicated case and you just come successful. Now imagine if you are working in public health and you will say, okay, where is the maximum disease burden? Where are the maximum mortality? Where is the maximum mortality? And if you get an opportunity to work in these states, in a way, you are a part of that Mahayagya. Because when I'm saying that Gates Foundation is working in these states, that doesn't mean that Gates Foundation is driving the health impact. Or whether it is a polio eradication, whether it is MNCH, or whether it is look, if we want to work in one village or one block or one district, then probably any organization can think reasonably independently. But if your aspiration is supporting impact at scale, then we believe that government is the primary stakeholder. For impact at scale, no organization, including Gates Foundation, cannot independently achieve that. So we partner with the government, which is a primary stakeholder, and under their leadership, then we work. And I will say, being a public health professional working in these geographies is a absolute pleasure. It gives you an opportunity for the innovations. It gives you an opportunity for critical thinking. It gives you an opportunity of, okay, how do I work around the issues which are centuries old? So for example, certain biases or certain practices, how do you change that? Right? So it tests your every possible cell of the brain. And that's a extremely satisfying part of working in UP and BR. Many people say, oh, you are working in UP and BR, is it challenging? And I will say, no, it is absolutely not challenging. It is rather a very satisfying journey. Thankfully, I think, because I think the governments in both the states have shown a lot of stewardship also in some of the innovations, in a big innovations. And that's why, if you are looking at, for example, let's take the example of Bihar, for example. For a pretty long time, their indicator were below the national average. If you are talking about the recent NFHS data points, then it is no longer at the bottom, right? Whether it is MMR, whether it is NMR, whether several other indicators. But now it is no longer dragging the India's indicators. And that's the change these states are doing. If you look at many other, and I can speak later, but if you are talking about several process indicators which lead to the essential outcome of the in the maternal mortality or neonatal mortality, some of the processes which these states have developed, whether it is a human resource for health, whether it is supply chain, whether it is a digital health, I think if you want to see the health innovation at play at scale, then you should visit these states. So it's less about the challenges, but more about the opportunity that make
Absolutely.
you that make you very, very.
Absolutely. So
Yeah.
I've also, doing some projects like Madam mentioned. So we are also doing in different zones. So the optimizing C-section project I have been doing in across the country. 50 sites I have in across the countries. And
Yeah.
as you rightly said, when you compare the north versus the south, there are different challenges. The stakeholders, how they react, how they, their responses, the challenges are totally different. And as rightly said, small interventions will create bigger impacts, more success, when we work in these challenging states. And I think that gives a lot of satisfaction when we see that now they are not at the bottom. They are having much more, the way they are working the systems, how you improve them. I think rightly said, they give you a lot and lots of satisfaction, and the kind of population you're dealing with. I think that's again a really good way of thinking, that you're already working with 1/4 of the population of India. So I think these are, thought-provoking ideas which you have given us. Now, when you're talking of these states and overall also, equity and inclusivity, these are two factors. So how do these factors influence any interventions you design and any interventions you scale across these states?
I think one of the thank you, Suresh. I think one of the driving force for constantly being motivated in public health is you feel like you are a part of supporting equity journey. And I think if I am not the part of equity journey, I will become restless. And there are several ways. I think people are using several frameworks, and I don't have any problem with the several frameworks. People continue to use that. To me, if you ask me what is equity, I will say forget equity for a second. What is public health? I will define very simply. Public health is all about common sense. It's not that complicated. What is equity? Everybody should get an equal opportunity to live the healthy and the productive life. So when you are using the equity lens, one may think, oh, we are doing big, and the averages mask the differences. At a national level and at a state level, you may have the great averages. But then if you dwell deeper into it, you will realize, okay, this is the population which is not being served through this intervention. So for equity, our primary lens is which are the segments which are still missed. That is one. And if you use this as a benchmark, then the question is, how do we solve for it? One common and very easy to guess is the geographical access. I will give you one example for example. In maternal mortality, and because this is a Fogsi platform, so I will use, CMOC services are so critical if you want to bring down the maternal mortality, right? But the availability of CMOC services, which is commonly in common parley, which is called as first referral unit, if it is only restricted at a district level, and the distance is larger and the districts are larger, then you can't solve for it. Then how do you help create the increase in the number of first referral unit or the CMOC center and all possible approaches so that the CMOC services are available closer to the community? Okay, and you can solve for human resource for health and other related issues through this one lens. But equity is not only solving for the supply side issues. Equity is also the demand side issue and the softer elements of it. For example, if I am a poor woman who is reaching a facility and I am not being treated fairly, I may be facing two biases. One is the economic bias, and the second is the gender bias. And we say, oh, it may take several years and several decades to change that perception. But for example, in Uttar Pradesh, government of Uttar Pradesh initiated the gender, and we supported that, the gender-based trainings for all the health professionals across the facilities. Many times it's just an awareness issue that I am doing this, which is not fair. And I remember, because I attended some of those sessions, people actually cried during those sessions. Facility provider, whether it is a nurse, whether it is a doctor, whether it is a Aya, whether it is a ward boy, whether it is a referral transport major ambulance driver, etc. Because this training for everyone. So if you are talking about respectful care, because that is also equity issue. Because I am not respected, I am not given proper treatment, next time I don't go there. So one is the access and the supply side. Second is this. For example, if you talk about across the world, if you ask people, what are the three things you want to do in health systems that will change the perception of the people about the public health system? People will say competent human resource, sufficient and competent human resource. Second, availability of the drugs, diagnostic equipment. And the third, people are taking the decisions which are evidence-based. If you solve for generally 3, people will say, oh, you have done 80% of the job. And for even for the equity lens, we suddenly started figuring out, okay, supply chain, and we can talk later, but supply chain situation has improved dramatically and huge. I can show multiple data points to prove that supply situation in these states have improved beyond imagination. But then you will ask the question, okay, is it only you have solved for availability of the issue, or actually there are blocks and the cluster of villages where there is a high availability and high utilization, right? So for example, in just talk about the maternal anemia, and we were monitoring and we were constantly looking at the data points. What percentage of blocks are there which has got the high availability and high utilization, and which was roughly 5% at one point of time, and it has over a short period of time it has grown up from 5% to around 48 to 50%. And this 10x increase, because you are talking about the blocks, or there will be blocks which has got the low availability and low utilization also. Either supply is also not there and people are also not taking. Are these blocks and the cluster of villages reducing? So equity, it's not a rocket science. In polio, we used to say one thing: whatever will be measured, it will get improved. And that principle applies everywhere. So long as we are measuring some of the critical barriers and critical interventions, I think these are some of the ways we are approaching equity and inclusivity.
And absolutely, when we are talking of maternal mortality and neonatal mortality, if we don't talk of equity, and inclusivity, then we will never be able to, improve our data, because all these problems, related to access, related to availability of drugs, medications, procedures, health providers, they are more, in these marginalized, in these vulnerable populations, they are more needed. Absolutely, because the makeup of these, women is such that they are more vulnerable to all these disorders, the PIH, preeclampsia, PPH, infections, everything is there in higher scale in these populations. So definitely equity is so very important. And I would like to again mention respectful care, as you rightly said. If we are making things available, but we are not taking into consideration the respect, then again, everything is there, but women will never come to the hospitals and they will never, seek access to the things which are provided. So these 3 things which you have mentioned, these are really very important. I think when you are designing interventions and in public health, these are, the key factors, the key issues which should be taken into account. Thank you so much for bringing all those
Can I just
nuances.
add,
Very well.
Thank you, Surik. Can I just add one thing? I think it is not that people are not, and this is not for one state or 2 states. It is for, and I have worked in, I don't know in how many states and how many districts. I have seen across the board that we start loving our coverage indicators too much. We fall in love with our coverage indicators, and we fall in love with the great averages which are shifting. I think for equity, what is important is, let's take the polio example, and I will, because that principle is, even if the 99% children are vaccinated, let's search for that 1% child, whether it is in
Absolutely.
brick lanes, in nomadic places, railway station. Similarly, for everything, you will find such vulnerable populations or populations which are not benefited for one particular intervention. You will have to search for that, and you will have to devise the approach for solving for that. That's the simple and a very easy way in the at least easy approach to solve for equity.
Yeah. I love that, when you said when 99% success has been achieved, but that 1% is still remaining. We need to go to those places and provide best of best care to
Yeah.
those needy. Then only we are going to achieve that final success, what we say. Thank you for that. And I would also, when I went through your CV, I found that you have traveled across, the length and breadth of India and more than 200. I mean, that's huge. 400, 200 districts across India and often in very remote areas. What lessons have you drawn from these experiences that continue to guide your work? We are eager to listen to these experiences.
Surekha, I think I think this is a pre-travel. So people pay a lot of money to go every different places. I was fortunate enough to travel to all these places free of cost. So that's one. Two is, and I'm coming to the serious side of it, but having grown up in a small, tiny village, in a forest village of eastern Maharashtra, whether you are working in Chambal or Kosi River area or different challenging districts of India, you actually live your childhood again and again. So many people ask me कि भाई यार ये बड़ा challenging है, Chambal तो बड़ा. I have met all different stakeholders, all possible different stakeholders during this journey or travel in 220 plus districts in India. It's a just you evolve and you grow as a human being. I think just to be fair, in all fairness, I will say you evolve as a human. What are the common lessons? Simple. I think problems are similar. One, I think we are all as a development community and probably the entire academic world, we are looking for we make two mistakes. One, we think that whatever has worked for one small geography, which will work everywhere with the same fidelity. No, that is one. If you are planning to import the intervention for either in this country or from outside the country, you will have to contextualize for that geography. So contextualization is very, very important. Otherwise, the global and the national guidelines, these are the guidelines we take as a rule book. And that's the problem. So number one, how do you contextualize the broad guidance for specific areas? That is, if it is, I have seen monumental failures, I have seen monumental successes. Only because somebody didn't contextualize properly. That is one. Two is a principle of differential approach. While universalization is very, very important, but you will have to figure out, while I will provide these services to everyone, there is but I will disproportionately put my focus in these populations for these particular areas. And that's the difference between equity and equality. That difference we will have to keep in mind. Otherwise, our averages will look good, but we will continue to miss in select geographies or select population. Over the period of time, that will give problem. That is two. Third, you genuinely want, and several people are, and there are good-hearted people everywhere. If you want to improve the health systems, or if you want to improve the outcomes, you have to trade a balance between a short-term and the long-term goals. Many times we either move very quick because of several reasons, but we want the change tomorrow, day after tomorrow. Whereas for certain interventions, you cannot, for example, if I want to change the biases or respectful care, how can I? There is not a quick fix solution, right? If there are systemic issues, there are no quick fix solutions. There are no magic bullets for everything, right? So how do you trade the balance between short term and the long term? And the last I will say is, last I will say, at least this is what I take: prioritization, prioritization, prioritization. And within prioritization, what does prioritization means is, whatever you want to focus, start measuring it. Because if you are not measuring it, it will not. By and large, this is, I think the last point I will say, sorry, I'm just adding. If you decide to solve a problem, you will find enough champions and enough support groups to be with you.
Absolutely. And I
Yeah.
think when you travel, you learn more, you gain more.
Yeah.
Communities teach you a lot.
Oh, yeah.
Definitely.
Why?
Innovations come from community only.
Oh, yeah.
You
Absolutely.
learn from people. You learn from, as you said, contextualization. You learn from situations. So I think it's very important that you go in the community, you interact with people there, and you find champions there, and you learn from there, and then I think you get ideas and solutions also from the community itself. So I think that's very important, and you are very fortunate, and I envy you that you got this opportunity to be there. 200 districts. That's huge, I think. So very, very, inspiring as well. So, Deva, when you go in these different communities with different contexts, I think you need some innovation, some ideas, some novel ideas. So can you describe some innovations which you use, especially for maternal and newborn health in these, different geographies that you have visited, especially UP and Bihar?
Okay. So there is a long list and I think I want to caveat this answer, because innovations are laid by the state. They are innovations, and I'm very proud being the part of that journey of those innovations. I was one of the important thought partner, but these are laid by several people, and I just wanted. So I think when we are talking about the innovations, generally our mind talks about technological innovations, vaccine development, diagnostic development. Great, it is important, very important. But we rarely talk about the process innovations. Because guideline formulation to ek baat hai, implementing on the ground at scale is a different science. Implementation science, I think implementation science is a different world altogether. We don't give enough respect for a variety of reasons, and now the world is started giving respect. But implementation science itself is important science. Now, let me give you an example. I think we were struggling with, the states were struggling, and we were all struggling about how to make CMOC facilities functional, right? And if you take about one CMOC facility per 5 lakh population, the UP will need around 350, 400 facilities, CMOC facilities, and equivalently around 200, around 175 to 200 in Bihar. population density will make it to 350 also, that will be good. Okay. So you do everything on the human resource management and all that. You bring people, and state does done every possible innovation in the human resource book to bring to onboard the people. But then you cannot quickly bring the specialists, so you will have to do the task shifting, right? And with the Fogsi support, there is EMOC and the LSAS and EMOC centers and accredited personnel. But many people said, even though we are EMOC trained, I don't feel confident to do the cesarean section. Same the anesthetist. And there was a thought process, how do we now improve the capacity? Somebody said, okay, why don't we bring some trained doctors from outside and train? We will say, but how many times that people will come? Somebody who is actually doing the practice, how many times that person will be available? So what we said, and who will train them? Otherwise, we do have all the public health professionals. Suppose I go and train and people will say, bhai, when was the last time you have seen the patient? Right? So we partner with the medical colleges, and huge appreciation to the Fogsi, because many of those members were from are affiliated to the Fogsi. So whether it is the King George Medical University, Aligarh Muslim University, Banaras Hindu University, Gorakhpur Medical College, we started with the 4 medical colleges. It was for the first time in India where the medical colleges said, we will go to the districts and the sub-district level, and we will mentor the public health, we will mentor the treating surgeons there and the treating EMOG trained doctors there. Come back, we will do their scores, etc., etc. But just imagine a gynae ops professor, associate professor is traveling 200 kilometers just to train a CSC doctor at district. Now, this model, which is called as Regional Resource Training Center, RRTC, now it has expanded to the entire 75 districts. And I am proud to say that 20 medical colleges in UP have adopted in a way the districts, and there is a partnership between the medical education and the public health. Now, this is, and when I go to the field and people say, the professor from KGMU came and she said, I cannot prove myself wrong in front of her because she's coming from my alma mater. So, and doctors will take the pride that, yes, who is coming? Oh, somebody from my medical colleges. So this small innovation, I just gave you the example, this small innovations in human resource management system or human resource system, suddenly scores of those doctors and the nurses have tremendously gone up. I can go on. There is a...
I know.
Yeah.
But I think, Devendra, I can draw parallels with the EMOC project which we did in Maharashtra. I think this way back in 2007, under the leadership of Dr. Desai at the time, she was the Fogsi president, and she has started this EMOC project where we trained non-specialist doctors in EMOC. So we had medical officers, MBBS doctors being trained in the emergency obstetric care, and we also had this LSAS training for the anesthetists. So these both are very good innovations because, human resource is a big barrier. And if you're training these non-specialists, I think a lot of things, especially the emergency obstetrics is. So it's a very good, like you said, these processes, these innovations are important, more important than any other innovations. And definitely, as you said, data is also very important. How you monitor, how you look at your failures, you look at the processes. That data is also very important when you're talking of how you scale up the innovations. So could you also let us know how this data is being driving the decision making and driving the change in the health outcomes, as you rightly said, the processes and everything. How does data come into this, and how this translational research is affected by the data?
So data for decision making is such an important tool in public health when you are driving at impact at scale. So both the states have come up with something called as, the term is little command and control center, which is essentially a place where multiple data points will come together. And it will be a structured mechanism where the people will look at different data. So that is one part. So it's a more of a governance part. But the challenge in data comes when unitized data is not entered. So the attempt is made through the help of multiple digital innovations. And I think I will, looking at the time, I will say the multiple digital innovation. For example, in Uttar Pradesh, there is a Uttar Pradesh ke Swasthya Kendra, or for human resource management system, there is HRMS, for supply chain, DVDMS. For COVID, there is a COVID unitized platform, then UPD, something like that. And there are similarly for Bihar also. So I think one is, how do you create? So there are two, three things. One is, how do you create the platforms in such a way that there is a original data, unitized data is being added. One. Second is, how is the structured mechanism is there, both at the state level and the district level. That is two. And the third is interoperability of the data, because one data set doesn't speak with another data set unless and until for example, if I want to understand the performance of a facility, I need to know what is the HR system, what is the supply system, what are the quality of care indicators. So every data set should speak with each other. And I think both these states have created a mechanism where these things are taken care.
I think another good example of use of data is from Kerala itself, the state who is doing the best as far as maternal mortality is concerned. They do the audit so well, especially when you're talking of maternal mortality, morbidity. Now they are looking into morbidity.
Yeah.
And as you rightly says, these systems, if their infrastructure is there,
Yeah.
infrastructure is there, but if the data management systems also are working and somebody is looking into that data and finally bringing out the change after looking at the data, then I think we are going to achieve that figure which we are aiming of reaching the SDG goals.
I think
That's very important, I think.
one just small point. What we have found is, many times we think about only data actions at a very, very high level. For improving the quality of care, for improving the skills and competencies, we have put a nurse mentor in the select facilities. And then when this nurse mentor works with the medical superintendent and everybody and look at the data for that facility. So finally, at the end of the day, action will not happen at the highest level. Action will happen at the lowest possible unit level. So if facility is a unit, and if there is a system where somebody is providing a stewardship of putting the things together, looking at the data, having the quality meeting, what is called as quality meetings generally, then we have seen that their baseline to end line indicators have shifted significantly. And that's why I am a great proponent of review of the data at a local level, not only entry at the local level, but even the review at the local level.
Deva, it's like we can go on and on. The type of, the similarities which we have together in conversation, we can go on and on. But I would like to briefly know from you. See, I was feeling very proud when you talked of, gynecologists, professors, associate professors, faculty from so many medical colleges going into the community and working, selflessly, pro bono in the communities. You have mentored so many institutions. You have mentored so many professionals. What do you think are the qualities which are very, very essential for the next generation professionals, and what message you would like to give our youngsters when we are talking of public health? Briefly.
Okay. I I don't know the answer to this question. I will attempt. One is, you decide what is the North Star for. You cannot, unless and until you feel that, okay, because some people are introverts, some people are extroverts, some people are into data or something. So you will have to be very sure, okay, what do you want? So that is one. Otherwise, I have seen the people fitting into the DNA is something different, doing something different, and then there are challenges.
Yeah.
That is one.
So you should know what you want to do.
Yeah, number one. Two is empathy.
Empathy.
I think in the era of artificial intelligence and chat GPT, knowing the smart answer is not easy, not difficult. But empathy doesn't come from chat GPT or AI, right? If you are feeling the pain of the person, then you will create a mechanism. Human mind is intelligent mind. And I have seen across the spectrum, because now I have got a privilege of working with several youngster to senior people, where I have seen people as young as 20 or 22-year-old, they say, no, 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 I want to change the world. So empathy becomes a very, very important. I think several factors and several leadership quality we are all aware. But I think what is missing, I'm just pointing out. If there is empathy and your heart beats for the most important person, that is the last child, the last person on the uh, in the line, then I think you're all good for working in
Yeah, I
public.
remember my own childhood when I said I want to become a doctor. I never thought of the money. I never thought that I will be earning such a lot, and that's why I don't want to become a doctor. I always thought of how noble it is to serve. I always thought about that service. And I think if we have that kind of, and I'm proud that I have met number of youngsters who have that, still have the service in mind. I think that's very important, the empathy part and the service part for the communities. And I think that gives us great hope. So my final question for you, Deva, what is the greatest hope for future health systems in India's heartland?
All hopes. I think India has made a tremendous progress. If you are looking at the last 20 years, I think you look at any indicator and you can see how many lives are saved. So that is one. Two, there is a, with our GDP. So finally, you need money for making all these reforms. Health is on much on the political priority. The literacy rate has improved. The digital, while people see from challenge from different lens, but in health, you can any intervention, any technology, if you can use effectively for so it is there. For selectively from our mothers and children lens, the whole road condition and the infrastructure, reducing the travel time also is playing in such a critical role. So the country and the population, and I think I will quote this, when during the polio eradication, the whole world was saying India will be the last country in the world to finish the job, and we proved wrong everyone, and we did polio eradication to the to against the critics, and yeah. So when it comes to the innovations, when it comes to the critical thinking, India doesn't have any dearth of that talent. So I do have, and I'm seeing a lot of youngsters, emerging leaders who want to do something good for the society. So I do have all the positive hopes for health system of the country.
It is wonderful to listen to you, and it is wonderful to, have that hope in the mind. And really, India is the Vishwa Guru, I think now. So it's really wonderful to know that it is such a hopeful situation is there for health system. And thank you very much for bringing us these insights. And as we conclude, I would like to thank you from my heart, Dr. Devendra, for sharing your expertise and shedding light on this critical arena of scaling impact for women's health. Thank you very much.
And thank you, Dr. Surekha, for not only
Yeah,
inviting
and a very special thanks to Dr. Sunita Tandulwadkar, our President Fogsi, whose visionary leadership has made this platform a reality, transforming discussions into action and fostering meaningful change in healthcare dynamics. To our audience, thank you for tuning in and being part of this journey. Your engagement and commitment to advancing maternal health drives us forward. Stay connected for more thought-provoking discussions in the upcoming episodes of Gyan Pravah. Until next time, let's continue to learn, share, and empower. Good evening and take care. I, Dr. Surekha Taire, along with Dr. Devendra Khandai, would like to sign off. Good evening. Thank you very much.